This is a 12-pound Yorkie. Now that we have finished examining the gallbladder, increase depth to fill the ultrasound screen with gallbladder and liver. Fan or slide the transducer along the rib to the patient's right side till liver disappears. Then reverse directions and fan or slide along the rib to the patient's left side. When you reach the patient's xiphoid, you may need to jump over or slide around it. Continue fanning or sliding to the patient's left till you have seen all of the patient's liver. Reverse directions and slide to the patient's left side of the xiphoid. If you see or suspect a liver lesion, rotate the transducer to a transverse position. Fan the transducer as far cranially as you can. Then reverse directions and fan as far caudally as you can. When finished, rotate the transducer back to a sagittal position. When the diaphragm is on the left side of the ultrasound screen, the normal liver fills about half of the screen. This guideline only applies for a patient in dorsal recumbency. The liver should not extend over or beyond the stomach. The liver is homogeneous except for blood vessels. If falciform fat is seen, the normal liver is the same echogenicity as falciform fat. The caudal and ventral edges of the liver are very angular. Look for lesions of hyperechoic or hypoechoic nodules, increased size, decreased size, mineralizations, dilated bile ducts, rounded liver lobes, or cysts. Examples of these lesions are shown in the liver DVD. Landmarks are important to help you identify structures you do not recognize. The diaphragm is cranial to the liver. The normal liver is a homogeneous structure filling the cranial half of the ultrasound screen with the patient in dorsal recumbency. At the ventral midline, falciform fat is ventral to the liver. Note that falciform fat and liver are similar in echogenicity and appearance. The stomach is caudal to the liver. Mirror image artifact has been discussed. It is important to recognize this as artifact but not ignore structures like the heart or lesions like tumors or effusions. Adjusting depth to fill the ultrasound screen with liver helps reduce mirror image artifact. Placing the diaphragm to the left side of the ultrasound screen also reduces this artifact. Liver dorsal to the gallbladder often shows a hyperechoic appearance known as through enhancement. In the Tips and Techniques DVD, we showed that the ultrasound beam and the reflected return is partially absorbed and weakened as the beam penetrates deeper and deeper in a homogeneous tissue like the liver. We showed that the time gain compensation toggles are used to enhance the ultrasound beam and the reflected return at increasing depths to obtain a homogeneous image in a homogeneous tissue. The normal gallbladder is not the same echogenicity as the liver. Normal bile in the gallbladder is anechoic. That means there is no absorption, weakening, or reflection of the ultrasound beam by normal bile. In spite of that, we have enhanced the ultrasound beam in the gallbladder. Therefore, the enhanced ultrasound beam reaching the liver dorsal to the gallbladder and the reflected return from there are much stronger than the part of the beam cranial and caudal to the gallbladder at the same depth. This results in the appearance of a hyperechoic liver artifact dorsal to the gallbladder. Reduce or eliminate this artifact by decreasing gain in the area of the gallbladder and just dorsal to the gallbladder. There are no standard measurements for liver size. Normally, I measure any lesions present as a baseline to compare to in future studies of the same patient.